would like to start our session now. We are running shortage of time. Our first speaker is Dr. Prof Moeen Alsayed. He is a senior pediatric and genetic disorder consultant at King Faisal Specialist Hospital in Riyadh. Prof actually Moeen from the beginning, since more than 20 years back, he was coming here through outreach program in Jizan and was giving a lot of help for us that time. Prof Moeen will talk about the emerging therapy for genetic and metabolic disease. You have 25 minutes, Dr. Moeen, to start. The floor for you, Dr. Moeen.
السلام عليكم ورحمة الله وبركاته. شكرا على المقدمة اللطيفة. It's been a long time since I've been in Jizan. It's really a privilege to come here. احنا في الأول كنا نتصدر من التخصصي على جيزان على أوتريتش، بعدين صدرنا لكم ثلاثة من أفضل أربعة صحيح، 3 gentlemen and 1 female. كلهم ما شاء الله من تخصصي ومن افضل الترينيز اللي مروا علينا في البرنامج. And I'm sure they are going to make a huge difference. They are already making a huge difference and they will make much more. And Jizan is an area that is also endemic for genetic and metabolic disorders, and we only know the tip of the iceberg. There is still so much more that needs to be discovered. So, I'm going to talk about emerging therapies for genetic and metabolic disorders. So, as you know, there are more than 7,000 rare diseases in our home, 80% of which are genetic in origin, and treatment is only available for fewer than 5%. So, if you translate that, and most of these diseases are monogenic diseases that are caused by single genes. So if you translate that, there are more than 400 million individuals that are suffering from rare genetic disorders. And with the next generation sequencing technology, now we know that probably the number is much higher than that, because we are really finding patients with a wide variety of phenotypes that are eventually diagnosed with NGS with one or other rare genetic disorder. So my outline is going to be just 3 main points: the general understanding concepts and treatment of genetic diseases as I see it, the approved marketed therapies and the emerging treatments. Since I've been involved with lysosomal storage diseases for a long time and newborn nerves, I'm going to focus on that and then a few conclusions. So my own sort of experience and intake on this, as you know, in our genetic disorders, it all starts with a gene and then ends up with the protein or the product. So these are the kind of treatments that are directed to genetic disorders at different levels. So you have at the genetic level, the main disruption here is a mutation, pathogenic or likely pathogenic mutation. And the treatments that have been available or becoming available include replacing the gene. A very old treatment has been organ transplant and stem cell transplant, adding the gene to gene therapy like in adenosine deaminidase deficiency or lipoprotein lipase, or now with the MPS disorders, editing or overriding with etolurane and some other products for Duchenne muscular dystrophy, antisense therapy for Duchenne muscular dystrophy, spinal muscular atrophy, silencing familial amyloid neuropathies and hypercholesterolemia, and reprogramming, which I'm going to talk a little bit about, sickle cell anemia and thalassemia, and then the combination of gene therapy with stem cell therapy, and the approved product is for metachromatic leukodystrophy and MPS1 is coming as well. The messenger RNA technology, which has been long awaited, so this is either you have a decreased messenger RNA because of a mutation in the gene, or an absent messenger RNA, or a misfolded messenger RNA. And in all these cases, you have the idea is to introduce a normal or modified messenger RNA. And diseases where work is going on is MMA, propionic acidemia, glycogen storage disease type 1 and 4. Enzyme replacement therapy, most of you are familiar with enzyme replacement therapy. We have enzyme replacement therapy for a good number of lysosomal storage disorders, and now also in other diseases, big values in PKU. And then you have a combination of enzyme enhancement therapy with chaperones, so like a miglustat in Fabry disease. Cofactors have been there for a long time with biotin and biotinidase deficiency, pyridoxine in homocystinuria. Substrate is typically increased in a metabolic disorder, and there are many different ways of reducing the substrate by reducing the intake or enhancing the excretion or substrate inhibition. The last of which is lumasiran or primary hyperoxaluria. Then you have a product that is decreased, and then the therapy would be to replace this product, like in urea cycle disorders, replacement with L-arginine and citrulline and bile acid and bile acid synthesis defects. So I have to mention this because this is the most recent drug that has been approved, and actually this is a real historical milestone in December 2023 with Casgevy, which was approved as the first CRISPR-Cas9 human gene therapy for sickle cell anemia, with a very and subsequently also approved for transfusion-dependent thalassemia. And this is a technology that basically uses a way to edit a gene that is responsible for silencing hemoglobin F production. So by silencing this gene, you improve the production of fetal hemoglobin and thereby improve the oxygenation. So this was approved in December 2023 and with a response of 93.5% of the primary endpoint in sickle cell anemia, which is basically prevention of vaso-occlusive crisis. It was then approved for transfusion-dependent beta thalassemia. This is really a historical milestone in the treatment of genetic disorders, and others are going to come. Now, this is the other product which also targets sickle cell anemia, and this is a gene therapy with a lentiviral vector for sickle cell disease, and it was simultaneously approved in December of 2023 for sickle cell patients 12 years and more. So, going to my more focused area of lysosomal storage disorders, so there are 31 products that are approved in the LSD space so far. So these have a wide variety of targets. The majority are intravenous administration, with the remainder being oral, topical, and intracerebral, cerebroventricular formulations. 22 of them are proteins, mostly enzyme replacement therapy. 7 are small molecules, with 1 molecule with 2 indications, which is miglustat, indicated for Gaucher disease as well as for Niemann-Pick C. And then you have 1 gene therapy. So these are a total of 31 products that are approved by the US FDA for the treatment of lysosomal storage disorders. And they start from 1991 with Seridase all the way to Welminix Alpha in 2023. So just to highlight some of them, I can't highlight all of them, just to give you some of the important milestones here of already marketed treatment. So this is Orchard Therapeutics with the combination of gene therapy with stem cell therapy for metachromatic leukodystrophy, and it is quite an effective medication with the Lancet and New England Journal of Medicine publications on metachromatic leukodystrophy. The other one I would like to highlight is this JCR Pharmaceuticals with Pabinafusp alpha. Now this is an interesting Trojan horse technology, whereby this is an intravenous intravenous enzyme replacement therapy for Hunter, but it crosses the blood-brain barrier through the transferrin receptor. So this is another big milestone. It is approved in Japan, it is approved in Brazil with limited access, but now it is in phase 3 clinical trial in the US and some other places. And this is going to also impact the way we manage our patients with these disorders. You already know of alipidase alpha, which has been approved for Niemann-Pick disease, and this is a medication that's been in making for over 25 years. And I've been involved in the clinical trials related to this disorder and in the advisory board for this particular condition. Now, this is another product that was added for Pompe disease, and it's glucosidase, and basically it has more mannose sugar moieties, so it has a much more affinity to mannose receptors and other receptors, and this is also changing the landscape of Pompe disease. And it is replacing myozyme even for the infantile type, although it is approved for the late onset Pompe disease. So now we move on to the therapies that are under development, and this keeps on changing. So this is something that I compiled in mid of 2023, so there might be some changes, but there are 61 products that are under development for lysosomal storage disorders. And now you can see the shift in the strategy. So in the marketed one, you have one gene therapy, which is for the metachromatic leukodystrophy. Now here you have 27 gene therapy products that are under development for lysosomal storage disorder, followed by small molecules, followed by proteins and messenger RNA and cellular therapies and others. So based on the likelihood of approval, I will just highlight a few of these disorders for you. So this is for Fabry disease. You can see there are 4 products that are in there for Fabry disease. And the first one is an enzyme replacement therapy with an 88% of possibility of approval, and we expect this in any time in 2024. Then we have a small molecule therapy for Fabry disease with a 52% chance of being approved by FDA. All right. So moving on to Gaucher disease, this is a small molecule, vinglustat, which has been in clinical trial for some time, and it penetrates the blood-brain barrier. And this is something that is expected to impact Gaucher disease type 3, the neurological form of the disease. And it has also a reasonably high possibility of approval by FDA. Ultragenyx is developing a viral gene therapy for glycogen storage disease type 1, glucose 6-phosphatase deficiency, and this is also expected to gain momentum and approval by FDA. GM2 and GM1 gangliosidosis, for whatever reason, is being worked at with viral gene therapy and a small molecule, and the one that is under, again, the same product, the vinglustat, is also going to be indicated for GM2 gangliosidosis as well as Gaucher disease type 2. In the mucopolysaccharidosis space, there are several products that are under development for Hunter syndrome, and these all have a reasonably high approval possibility with 58%. And these are products that are related to gene therapy as well as enzyme replacement therapy for Hunter syndrome. The other drugs that are in pipeline is a drug for mucopolysaccharidosis type 3A. It's a viral gene therapy. So it's a viral gene therapy with a 57% LOA, and this is an intracerebral cerebroventricular therapy for Sanfilippo type A. Niemann-Pick disease also is really, so this is Niemann-Pick C, and there are at least 1, 2, 3, 4, 5, 6 products that are under development in phase 2 and So you can see, the landscape is really impressive. There's also another product which is very interesting for Pompe disease, which is a combination of enzyme replacement therapy and substrate, small molecule therapy. And this is really, I think this is going to have a major impact, and there is an 89% possibility of approval through amicus company. All right. So other therapies, as you know, achondroplasia. Achondroplasia, the drug that is already approved is Visoratide, which is in the yellow there, as you can see. And this drug is already available in Saudi Arabia, and I think there are more than 20 patients that are in treatment with Visoratide. And interestingly, the tyrosine kinase inhibitor, infigratinib, is an oral molecule that targets the FGFR3, and it completed the phase 2 clinical trial with very good outcome, and it is in phase 3 clinical trial right now, and it's expected to gain approval by the end of 2023. So it's an oral molecule actually for achondroplasia, but you can also see the number of products that are under development for achondroplasia. So this is exciting for us as geneticists. Now, this is a product for arginase 1 deficiency, pegzil arginase 1. And what I want to sort of highlight here is the newer technologies and the innovative science that is being developed with these disorders. So you can see this particular enzyme, what they have done is they have replaced the magnesium with copper. And by replacing the magnesium with copper, the catalytic activity of the pegylated of this enzyme compared to the human arginase is much higher, as well as the serum stability. So by doing this, there is a significant improvement of this particular enzyme over the human naive enzyme. And with this, the phase 3 clinical trial for patients with arginase 1 deficiency, as you can see, showed significant improvement from a patient who is unable to cross legs and is dependent on walking aid. So you know these arginase 1 deficiency, they have resembles cerebral palsy with spastic diplegia or paraplegia. And then 20 weeks into treatment, she is able to cross her legs and is dependent and is less dependent on walking aids. And there is an improvement in the 6-minute walking test. So this medication is just approved very recently by the European agency, and is expected to, we expect to have some patients on this as well. Now, I know Professor Majid is going to talk about gene therapy, but just a couple of points that this is among other diseases outside the lysosomal storage diseases where gene therapy is under clinical trial. There are several trials for Canavan disease, for X-linked leukodystrophy, and for phenylketonuria. But I just want to highlight a very important point, that there is a misconception that gene therapy is good for everybody. It is not, and it may be only applicable, and the patient that will be eligible for gene therapy is a subpopulation of the original patients with the disease. So if you have on the top of the triangle, you have the total population with genetic disease. Those that have been exposed to AAV are excluded. Those that have disease progression beyond the possibility of with end-stage or advanced organ damage may not benefit from treatment. Patient age and comorbidities also are a factor. So at the end of the day, if you have 100 patients with a particular genetic disorder, you maybe have 1 or 2% of those that are eligible for the gene therapy. So it's not going to be for everybody. And this is something that we should know. And that's why the other therapies are very important, with the small molecule, with the enzyme replacement therapy, with the messenger RNA, and so on and so forth. So just to give you what's happening in the gene therapy area, And this slide really is a busy slide, but it kind of sums it all. So you have the green ones are the in vivo therapy, and the red ones are the ex vivo therapy. And in the middle, the black one are already marketed products. So that is about 9 or 8 products that are already marketed as gene therapy. The darker gray are in phase 3 clinical trial. The lighter gray are in phase 2 clinical trial. And then the lightest gray is in phase 1 or phase 1-2. And then the top ones are in the preclinical trial. So you can see the number of gene therapy products that are either marketed or under development in different phases. And you can also see the number of companies, around 40 different companies that are working on gene therapy. So that is exciting. So I think in summary, we have always been dreaming about, a oral pill or a drug that will treat a genetic disorder, or multiple genetic disorders can be treated with one drug. And etoleurin, was one of those medications when it came early on for stop codon mutation. There was this excitement that it might be useful for all the stop codon, mutations, regardless of the disease. But that has not been the case, and I think it's a long way since we will have that capsule that will fix many of these genetic disorders. But we have made tremendous, advances in different technologies. The most advanced, the most exciting one is the CRISPR-Cas9 technology. But there are other technologies with a small molecule and with some innovative science for development of treatment for genetic disorders. The messenger RNA technology looks very robust and appears to be something that we are going to see in the next coming 10 years as one of the leading therapies for genetic and metabolic disorders. But with this also comes a lot of other challenges. So there are challenges in terms of the cost of the medication. There are challenges. Once you have a gene therapy product that is approved, then there will be a call for early newborn screening. Or whenever there is an effective treatment for a particular disorder, then hand in hand you need to have a newborn screening project or a newborn screening initiative that includes these disorders. So that is a challenge. The cost is a challenge. Some of the ethical issues with genomic editing, whether there is off-target, effect of genomic editing, and also the reach for these medications for everybody. There is definitely inequality in care. And we have seen this in COVID-19, where countries that had massive resources were able to get the vaccine very quickly, whereas other countries have struggled with it. And the same thing is going to happen with these kind of effective therapies. So for sickle cell anemia, the cost of Casgevy is almost $2.5 million US. So is everybody going to get that medication? Probably not. But it's a one-shot medication with a 93% achievement of the primary objective, which is prevention or reduction in the veno-occlusive crisis. So it's a life-transforming medication. After the US, Bahrain was the second country that approved the medication. The UK has approved the medication, and the Saudi FDA just last week have announced approval of this medication by Saudi FDA. So thank you for listening, and if there is any time for questions, I will have.
Thank you, Prof Moeen, for this interesting lecture. May I call the second speaker, Prof Majid Al-Fadl. He is a pediatric genetist at National Guard Hospital in Riyadh. In the morning, he gave a lecture about Wolman disease, and now we will talk about the gene therapy, current status, future, and other challenges also.
medication always difficult to pronounce. Like Infigrimin tab and Vosoritide and Cibialabase alpha. While endocrine, very nice, statin, but it's very antibiotic, penicillin, gentamicin. Yeah, I think it reflects the people in the specialty.